surgeon from Liverpool, co-chairs Tom Routledge there. We got 4 debates in this session. First one's looking at surgery and adjuvant chemotherapy for single station N2 disease, and we got J Maguire, oncologist from Liverpool, and Simon Jordon for the talk on that. Following that, we've got sublobus resection versus stereotactic radiotherapy. Pleased to welcome Shireen Ahmed from Guy's and talking with Sean Barnard. We'll have a coffee break after those two, then following that and talk on pulmonary metastatectomy, should they be done outside a trial, and then at the end, should patients with suspected lung cancer get referred straight to us as surgeons, or should we continue with the system as they are, where they go to the chest physicians? You're all surgeons in the room here. You all have views on things. Often they're fairly one side of the fence or the other. So after the debates, we'll take questions for the speakers, and then if there are no more questions, I'll be going around asking members of the audience what they think, what they do if they have such a patient in the MDT. So moving on to the first debate. The patient, is surgery and adjuvant chemotherapy is the treatment of choice for patients with single station N2 disease? So speaking for this, we've got Simon Jordon from the Brompton and Joe Maguire, who's an oncologist in Liverpool and is chief investigator on the SOCCA trial, which is trial of sequential versus concurrent chemoradiation for patients with lung cancer. So this is a typical case you get in your MDT. You know, a 74-year-old lady presents with some hemoptysis, bit of COPD, very mild angina. She's a mass in her left upper lobe, and CT biopsy of it shows an adenocarcinoma. And she has a PET scan. She's got a node that's very hot in station 5. And biopsy it, and station 5 nodes involved with adenocarcinoma. So it's where do you go from there? And I'll hand over to Simon, who's going to give the argument for surgery.
Thank you very much. This is an interesting topic, I think, to debate. I think a few years ago, 10, 15 years ago, nobody would be having this debate, but things are changing. 10, 15 years ago, nobody would ever dream of deliberately resecting N2 disease, I don't think in the UK. And any mention of a patient with N2 disease in an MDT, if there was one, would direct the patient immediately away from the horrible surgeons. But things are changing. This is the previous set of BTS guidelines from 2001, and I quite like these. They were quite simple. They gave us a fairly straightforward guidelines. They were a little bit on the conservative side. And to be fair, our understanding of lung physiology in the perioperative period was not as good as it is now. But the guidelines were fairly clear. We resect patients with N1 disease, but we wouldn't go near a patient with N2 disease. But I'm going to talk a little bit about the IASLC, the recent work that's been done by this group, the updated guidelines from the British Thoracic Society in conjunction with this society, a little bit of the previous literature on the subject. And I also want to talk a little bit about surgical advances, because there have been changes in surgical practice and what we can potentially offer patients. And maybe we should consider surgery in selected patients. The International Association for the Study of Lung Cancer has taken lung cancer staging, I think, although the changes haven't been very dramatic, it's now based on a much larger cohort, over 100,000 patients worldwide, rather than just a small select group from MD Anderson. And one of the things that's come out of this group is a much clearer definition, a much clearer idea of what defines individual nodal stations. I remember when I was Peter Goldstraw's SHO quite a long time ago, Peter and Sunichi Watanabe, a Japanese surgeon, carried out a little study looking at individual lymph nodes, and intraoperatively they were both blinded to each other's comments. They would state which lymph node station they thought each lymph gland was in, and they disagreed disagreed in 30% of the patients, and this is two surgeons with a real interest in lymph nodes and lung cancer. 30% of the patients, they disagreed with each other, and I think it's somewhere between 20 and 24% of the cases, these differences could amount to a change in the N1 versus N2 staging of the patient. Something else that's come out of this group's work with Valerie Rush and Peter and the rest of the group is the concept of lymph node zones rather than individual stations, and how this may be important in the staging and management of patients with lung cancer. I'd like to state, obviously, N2 disease is a very heterogeneous group of patients, and clearly nobody in this room would suggest that every patient with lung cancer and N2 disease should undergo surgery, even as part of multimodality therapy. But patients with N2 disease are a very heterogeneous group. At one end of the spectrum, we've got microscopic disease. At the other end of the spectrum, we've got multi-station, fixed, bulky with extranodal spread, and clearly these patients are not the same and should not be treated the same. We also know that different lymph node stations have different prognoses. As we heard in the introductory slide, patients with involvement of lymph node stations 5 or 6 with a left upper lobe tumour behave more akin to patients with N1 disease. And probably stations 8 and 9 in lower lobe disease are less important than patients with central mediastinal disease. This is some of the work done by the IASLC, and they looked at patients with single-zone N1 disease and multi-zone N1 disease versus multi- and single-zone N2 disease. And interestingly, patients in green with single-zone N2 disease have a similar prognosis after surgery to patients with N1 disease, with multi-zone N1 disease. The BTS guidelines in conjunction with SCTS went so far as to say that we should consider radical radiotherapy and chemoradiotherapy in patients with pure fixed N2 disease. We should consider surgery as part of multimodality management in patients with N2 disease, non-fixed, non-bulky and single zone, not single station, and even consider further randomized trials of surgery as part of multimodality therapy in patients with more advanced N2 disease. This study, published in 2002, this phase 3 study, looked at patients undergoing chemotherapy and radiotherapy and compared them with induction chemo followed by surgical resection in the setting of N2 disease. And they found that the median progression-free survival was 14 months. There was no difference in the 1-year survival rate, 70% in the surgical group, 66% in the chemoradiotherapy group, and the median survival times 19 months in surgery, 17 months in chemoradiotherapy, with no significant difference. This MRC group, published in 2005, looked at a randomized group with patients who had undergone preoperative chemotherapy compared with chemoradiotherapy, and similar findings. Overall survival similar in the two groups, median survival 11 months in the surgical group versus 13.8 in the chemoradiotherapy group. Van Meerbek's EORTC group, published in 2007, and they again looked at a randomized control of surgery versus radiotherapy after induction chemotherapy in patients with N2 disease stage 3A, and found no significant difference. Graphs over the lines of survival curves overlapping. And Kathy Albane's group with Valerie Rush looked at radiotherapy plus chemotherapy with or without surgery, if possible, in non-small cell cancer in patients with N2 disease. And the overall, as you can see on the graph on the left, the overall survival was improved if a lobectomy was possible, but these did not follow through if a pneumonectomy was required. So what else has changed? Well, compared with those historical, not long ago, but historical series, I think our preoperative workup or our assessment of patients in the MDT is better. The availability of PET scans or PET CT scans, the resolution of newer CT scans, I think is much better than previously. I'd also like to suggest that we should always confirm pathologically the presence of N2 disease rather than taking CT criteria or even PET criteria as definitive or diagnostic of N2 disease. And I think the advent of EBUS TBNA, video rather than the old-fashioned mediastinoscopy, will help stage patients more appropriately, more accurately. We should also bear in mind that there have been changes in surgical practice. Most of the people in this room, I suspect, are thoracic rather than cardiothoracic surgeons. Although the number of cardiothoracic surgeons around the country has remained pretty stable, there's been a very big increase, thanks in part to cardiologists, in the number of pure thoracic surgeons. And I think maybe we don't do anything differently, but I think the availability of thoracic services has meant that there are more patients being seen and assessed, more theatre space, and I think patients are getting a better deal. The preoperative assessment, I think, is more accurate. We understand lung physiology better than we did previously. Post-operative care is better. The intensive care mortality rate for ARDS, which was traditionally the biggest killer in the early setting post-lung resection, has reduced from almost 100% mortality to less than 50% in the last 15 to 20 years, partly with permissive hypercapnia, extracorporeal circulation support, and just better general management. We're also offering different surgical options such as sublobab anatomical resections, even thoracoscopically performed. We're offering sleeve resections with greater frequency, preserving lung and in many cases avoiding the need for a pneumonectomy. And hot topic, the number of VATS lobectomy has been going up fairly consistently year on year. Despite the fact that there are more thoracic surgeons and a lot more thoracic surgical resections, there's been a 60% increase in the past 4 or 5 years, presumably because we're taking on more advanced patients or patients with poorer comorbidity profiles, poorer lung function. Despite this, there's been a roughly 50% reduction in the number of perioperative mortality, which I think is fairly impressive. And as you can see from the graph at the bottom, the number of VATS lung resections with a younger generation of surgeons seems to be going up year on year. So I think surgery has changed. What we're able to offer has improved compared with 10 or 20 years ago. There's greater access to thoracic surgery services. I think it is safer. I think the advanced techniques, including more rigid adherence to ESTS, IASLC, insistence on systematic nodal dissection, the availability or the prevalence of VATS lobectomy, and possibly with an improved patient recovery, maybe allowing in patients with nodal disease to get onto chemotherapy and complete chemotherapy more often. The evidence, or the historical evidence, is not very clear, but when we note that the patients with N2 disease is a heterogeneous group, I would suggest that at very least surgical survival is similar to radiotherapy alone. And in selected patients, possibly single zone, possibly single station, patients may fare better with surgery or with multimodality therapy, including both surgery and radiotherapy, as well as chemotherapy, will become an option. I therefore suggest that surgery should be part of multimodality management in selected patients with N2 disease. So is there any debate? I would suggest no, not any longer. I think we should treat each individual patient as an individual patient. We should personalise their therapy, including surgery, according to their disease. We should challenge prefixed or fixed preconceptions and consider surgery in patients with limited N2 disease at least. Thank you.
Thank you very much, Simon. And well, as I say, hand over to J Maguire now.
If I can get this to work.
Which one's yours? Is that
this one?
No, that's mine. That's. Is that science? Okay, just close these down, and then this. Yeah.
Have we managed? We have, yeah. So it's this one for forwards, is it? Or?
You want a better slideshow? Is that your presentation there?
Yeah, that's it. It's up here just now then. Fine.
You need to go to slideshow. That's it. But you need to go to... Is it on a stick or is it on...
No, it's in the network and it's on the computer, we're talking. So, can I just move this forward and use
No,
it?
you should have a screen for it. I don't know why it's not coming up like that. 'Cause just try the space bar. But it should come up. It was working fine.
Yep, so how do I go back then?
I think I need to change it. I need to reopen it then. I don't know why it's done that at all. So you're here. So let's do this. And that's you there.
So, to move it forward when I want
That's
to.
it. You should just go on to there.
Just go on to that then. Yeah, okay, got you.
Well, at last, thank you for your patience. Thank you to Simon for what I felt was a very interesting talk, which I don't have major disagreements with. And thank you also to Mike for asking me to speak at this meeting about this interesting topic. Please forgive me for not being able to work this thing. Not again. Yep, got it. Okay, forgive me for starting with a mild degree of controversy. The gentleman on the right is George Mallory, a mountaineering pioneer, born and brought up on Merseyside and something of a local hero, died climbing Everest in 1924. When asked why he was obsessed with climbing Everest, Mallory's famous reply was, because it's there. And also because he felt technically he could do it. I'm going to try and convince you that because it's there and because technically you can do it aren't good reasons for operating on N2 disease. Here's an overview of what I'm going to talk about. I'll briefly discuss single-station N2 disease. I'll talk about the proposal. There are real difficulties in practice and differences between what we see in the published journals and what we see day to day working in our clinics. There are some therapeutic options which are worthy of consideration, and I'll finish with some suggestions at the end. So, here first of all are some surgical results which are better than any of you will get in your normal MDT practice. And that is because it's a more highly selected group. This is a retrospective review from the University of Alabama, looking at 148 patients who had undergone complete resection and thoracic lymphadenectomy, but who were not expected to have nodal involvement. So this was a retrospective review of how this group of patients did. This is a occult N2 disease. So different from what we'd see with, for example, a patient with a hot PET scan, as Mike showed. Unusually, again, compared to our practice in the UK, 93% of these patients had adjuvant chemotherapy and actually completed it. 15% also received adjuvant radiotherapy. The 5-year survival in this group unsuspected N2 disease was 35% overall and 40% for patients who had a single involved unsuspected lymph node. So yes, single station N2 disease, these patients do better than patients with multi-station N2 disease, but they still don't do well. These are still bad results overall. And the reason for that is that N2 involvement, even at single station level, is a major risk factor or a predictive or an indicative factor for the presence of occult metastatic disease. Even single station N2 patients, as Simon says, are a heterogeneous group, and there are other risk factors which need to be considered, particularly size of the primary tumour. The larger the primary tumour, the higher the risk of there being metastatic disease which is present but which won't show up on PET or CT scans. But there are advantages to immediate surgery. First of all, clearly we get immediate local control of the tumour and any tumour-related symptoms. We get definitive staging of the mediastinum, and we can't rely on PET-CT for that. And also, achieving definitive mediastinal staging makes the results for single-stage disease better, because we're excluding patients who actually have occult multiple station N2 disease. Also, any residual disease should be at a microscopic level and should, following surgery, be outside of the previous surgical field. And then can we do anything about that? Yes, we can. Adjuvant chemotherapy makes a small but significant difference to cure rates, 5-year survival for patients following surgery for non-small cell lung cancer. And there's a strong advantage, particularly for patients with stage 3 disease. This is the IALT study, which is one of the biggest individual studies, showing what comes through from most of the overall literature, approximately a 5% survival advantage at 5 years for patients who receive adjuvant chemotherapy, cisplatin-based, as opposed to observation. This magnitude of advantage is similar to what we see in breast cancer with first generation CMF-style chemotherapy. This is the LACE meta-analysis, which looked at the 5 largest trials which were recruited into and published after 1995, a total of 4,584 patients. And the LACE meta-analysis, lead author on it was Le Chevalier, and a number of co-authors showed a 5-year survival benefit from cisplatin-based chemotherapy of 5.4%, with a convincing hazard ratio and p-value. A subgroup analysis pre-planned showed that cisplatin and vinorelbine provided superior survival benefit to other combinations and is recommended by the LACE group. Now into the real world. This is Liverpool, and Liverpool has the highest incidence and highest mortality from lung cancer in England. Our lung cancer clinic in the Heart and Chest Hospital, which Mike and I work in, is the largest lung cancer clinic in the network, and I think the largest in England. When we take these published results to our day-to-day practice, then a bit like this photograph, things start to get blurry around the edges, because there are difficulties in practice, and these are results I've recently been looking at and are not yet final, but these worry me. In Merseyside, only 60% of patients who are referred for adjuvant chemotherapy are actually considered by the oncologists, including myself, and I'm an enthusiast for actually giving treatment. Only about 60% are suitable for immediate adjuvant treatment. There is a substantial group where we watch them and treat them on relapse, but that's not adjuvant treatment. Hardly anyone in our area is able to tolerate cisplatin, and both myself and my colleagues find ourselves using carboplatin as an alternative. Now, the evidence base for that is debatable, but we find ourselves in a day-to-day clinic situation of giving carboplatin-based chemotherapy or as an adjuvant, or not giving any at all. Even with carboplatin, we have about a 3% treatment-related death rate, which, when you consider the overall 5-year survival advantage from treatment is only 5%, if you're killing 3% of these people, it is not very good. And this is something we are thinking about very, very carefully. There are also problems with timing of treatment. First of all, from the studies, we would want to start treatment ideally within 6 weeks of surgery, and we are often not able to do that, partly because of the time it takes for patients to recover after surgery. This leads to concerns about accelerated repopulation, which is a well-documented phenomenon which is now recognised as being important in lung cancer, both in relation to chemotherapy and radiotherapy. Accelerated repopulation describes relates to the rapid increase in growth of cancer cells, which starts to become evident approximately 4 weeks after any oncological or surgical intervention. So if we're delaying adjuvant treatment for 8 weeks or more because patients aren't up to having treatment, that becomes a major worry. So there are significant problems. Because of that, it's reasonable to think of other options as opposed to what we've talked of as the notion of immediate surgery and adjuvant chemotherapy, which we can't deliver for many patients. One option is to give neoadjuvant chemotherapy into patients. Start with chemotherapy as a first treatment. This at least gets systemic treatment in first for patients who are highly likely to have systemic disease, admittedly probably occult. And this is the most well-known study in this area, EORTC 08941, Van Meerbeek being the leading author. Now, surgeons, in my experience, tend to hate this study. Despite that, I think that Van Meerbeek should be on everyone's list of 5 famous Belgians, probably somewhere between Herman von Rompuy and Inspector Poirot. In this study, he started with 579 patients who are described as unresectable. But if you go back and read the paper, the unresectable relates to patients having confirmed N2 disease. So these are not technically unresectable patients. These are patients who are identified as having N2 disease, either single station or the majority multi-station, before entering the trial. They received 3 cycles of cisplatin-based chemotherapy, and patients who derived any degree of measurable response then went on to be randomised to either surgery or radiotherapy. And that comprised 61% of the original 579 patients. And looking at the results at 5 years and in terms of median survival, there was no significant difference in this trial between surgery and radiotherapy. Now, I don't particularly like this approach, but for different reasons from many of my surgical colleagues who I've seen frothing at the mouth about it. I don't like it because you're starting off with 579 patients who are starting off eligible and suitable for some form of radical treatment, and at the end of it, or halfway through, only 320 are actually getting radical treatment. And that's because there's a limit to how effective chemotherapy on its own is for non-small cell lung cancer, and a proportion of these patients will either not respond or even progress. So I don't really have a great amount of enthusiasm for neoadjuvant chemotherapy as an approach for any patients with N2 disease. More interesting is giving concurrent chemoradiation, which involves simultaneous administration of full-dose radical radiotherapy and full-dose chemotherapy. And this has been shown to provide a genuinely synergistic effect. It's better, more effective than giving one or the other, and more effective than giving one after the other. Probably this works by avoiding accelerated repopulation, which I already described, and that's particularly effective if we give the whole block of treatment within a 4-week period, which is what we've worked on in Liverpool over the past 15 years. Concurrent chemoradiation is now an international standard for inoperable stage 3 disease, but the elephant in the room is, how are you defining inoperable? It can, if necessary, be followed by surgery in selected cases. But not every patient is suitable for this. Critically, patients have to have a good performance status, PS 0 to 1. Lung function, to be adequate for this treatment, really, to my way of thinking, probably requires a TLCO of at least 50% and an FEV1 of at least 50% of the predicted value. We're looking to cause scarring of less than 30% of normal lung tissue. That's what V20 refers to, the volume of lung tissue as a proportion receiving 20 gray or more. Developments in radiation technology make it feasible for us to treat bigger tumours. That won't make the overall results better, because bigger tumours tend to do worse because they're more likely to have metastatic disease. And obviously the efficacy of this form of treatment will be influenced by how radiosensitive the tumour is, and we don't have any predictive measures for that. These are 3 studies which have looked at giving concurrent chemoradiation in the way we do in Liverpool, 55 grain 20 fractions, full biologically radical dose with concurrent cisplatin and vinorelbine. Our developmental work in Liverpool, we've produced and reported 2-year survival of 61%. In SOCAR, which Mike alluded to, where we brought this treatment across the country to a number of different centres, patients are randomised to concurrent or sequential chemotherapy and radiotherapy. Again, an impressive 2- and 3-year survival. Because of the difficulties of starting clinical trials in this country recently, 5 centres started a pilot study before SOCAR, and they produced very similar results. Median survival of more than 2 years. Now, these are patients with predominantly stage 3B disease, so this is more nasty disease at the outset than single stage in N2. But the results are still very good, and this is a worthwhile treatment option worthy of considering for patients who are suitable for it. This is Noelle O'Rourke's work, and there isn't an international or even a national agreement on the best regimen for concurrent chemoradiation. Different countries, different centres use different radiation doses and different drug combinations. But Noelle, who works with the Cochrane collaboration, looked at, for the World Lung Cancer Conference 18 months ago, looked at different published and presented work, and the SOCAR schedule, which we've used in Liverpool, compares favourably to anything else that's been described from anywhere else in the world, America included. It is possible after this treatment to proceed to surgery if that's appropriate for the patients. Now, in Liverpool, we've 18 of our patients have gone for surgical resection after this form of concurrent chemoradiation. But in 14 of them, there has been a complete histological response, this being one patient slide demonstrating that. Complete histological response, normal lung tissue underneath. So our feeling is we're not sure if surgery is required after this form of treatment for the majority of patients. And obviously surgery after concurrent chemoradiation has a degree of risk involved. We've had 1 post-operative death out of 18 patients. But genuinely, I'm not certain if it's necessary for the majority of these patients who've had concurrent chemorad. What we're presently doing is for patients who've had concurrent chemoradiation, we're PET scanning them at 3 months and 6 months, and patients who have residual metabolically significantly active disease in the primary tumour, we're considering surgery for them. Finally, and I was struck by how similar this conclusion slide is to Simon's. What do we do with this group of patients? It's a heterogeneous group of patients. There is no individual treatment which is right for all of them. And I would suggest that we should discuss the scans and histology, and then it's worth both the surgeon and the oncologist seeing the patients, either together or the same day or even sometime later the same week. The critical component in terms of determining prognosis and also guiding us in selection for treatment is performance status. My feeling would be that if surgery would require a pneumonectomy, then for this group of patients is not the thing to do, because there is a higher risk of mortality with pneumonectomy, higher morbidity rate, for a group of patients who already, even at single station disease, have a very high risk of having occult metastatic disease. So my suggestion would be that if it's going to need a pneumonectomy, the better to have concurrent chemoradiation. And likewise, because primary tumour size predicts for risk of metastases as well as N2 disease to us, then if for bulky primary tumours, concurrent chemorad is probably the better treatment. But that doesn't apply for everyone. My feeling is that for patients with lower lobe tumours, which are mobile or peripheral, then I think they're probably better treated with surgery initially, because the movement of the tumour either means that we have to treat a much bigger volume of lung tissue, or we have to get really quite complex in thinking of tumour immobilisation or tumour monitoring during treatment. And I'd also worry about the lymphatic channels in between the peripheral tumour and the mediastinum for this group of patients. So my feeling is that lower lobe, peripheral, mobile tumours, probably best thinking of surgery first, and then chemotherapy if we can get it in. If there's a worry about that, then maybe think about chemotherapy first, but these patients would need to be observed very, very closely. And again, I'm in complete agreement with Simon again. It's the individualised patient approach is required for the best results for this group of patients. Thanks so much, Mark.
Thank you very much, Joe. Does anyone any questions for Simon or Joe?
I think I'm a little bit more confused. I think the problem is when we're sitting in the MDT, and there are a group of physicians who are very, very aggressive. Oh, take it out, it's then to disease, single node, take it out, doesn't matter, do surgery, we'll give something. Another group who says, well, we have done the literature search, we have seen surgery and non-surgical treatment doesn't have much difference. NICE, again, doesn't recommend surgery, so why are we operating on them? I think we really need to have a clear-cut sort of a guideline or a consensus amongst thoracic surgeons how to deal with this patient. I mean, if there is a single station, less bulky disease, should we give neoadjuvant treatment or should we do surgery or should we do surgery? And then I think we need to really have I agree that there's a personalized approach, but that becomes, it's not very clear for
Would it be right to give clear-cut guidelines when the data don't put us in a clear-cut direction? It's messy territory scientifically, and we have to look at that. And make a falsely clear guideline just to make life easier would not be helpful.
I worry a bit about chest physicians here too. Chest physicians are marked by how many patients they get operated on. And there's a very, very strong motivation from them to push as many people into surgery as possible. And I've been to chest physician meetings where they're all kind of comparing their surgical resection rates, and that kind of, I think that affects their thinking processes quite a lot. And this is quite a heterogeneous group of patients, and I think we do need to look at them individually. There's not that many of them, that's the other thing, and that's another reason for looking at them, I think, on an individual basis too.
And that's something you were alluding to, the patients that are fit enough for you to give concurrent treatment to are the patients that are also fit enough to have surgery followed by chemotherapy, particularly baxdrostat. So is it this similar fit subgroup that you like to treat and we like to treat?
My worry then is that some patients just after surgery just don't get to the chemotherapy. I think the systemic component of treatment is essential.
Absolutely.
And I worry that some of them just don't get there. And I kind of have agonised on this about, why is it that these studies have been done which have patients have had chemotherapy, and why can we only give 6 out of 10 patients chemotherapy? But the reason for that is that when these studies were recruiting, then the oncologist would see the patient after surgery and I would look at them and say, would this patient tolerate cisplatin? And if the answer was yes, they'd be entered into the study and randomised. And that's different from what we're
It's a
seeing.
real world population.
Yeah.
The younger generation of surgeons hope that that's the way to do it. So it will increase the deliverability of post-operative chemotherapy, which is a good in principle, but you have to see whether that applies to the large real world population.
Question then?
I'm just wondering whether it's echoing of when they were trying to compare the Cabbage trial when all patients who had a small group of patients who had very selective coronary disease and medical treatment there. And I think if you're looking at the population now and the kind of surgery, and the patient's recovery from it, the time when the patient had to spend 2 weeks in the hospital after a resection, a lot of them now are having VATS, like Simon was saying, they're getting out of the operation much quicker, and they're much functionally sort of ready to undertake further treatment. So I don't know how much of the data presented in these trials are based on historical figures from patients' perioperative recovery, and what's the current state where we definitely got they're getting through the system much better, much quicker, and are in a better condition.
Well, the patients in the trials, the adjuvant chemotherapy trials, are patients who are fit for adjuvant chemotherapy after surgery. Now, in Liverpool today, we are able to give 60% of these people adjuvant chemotherapy. It's fascinating how we view things in the light of our own perspective and experience, because when I was preparing this talk, what came to my mind was surgery for breast cancer in the early 1970s, and surgeons, especially for one node positive breast cancer, and the surgical argument was, yes, we should do this because we can, and maybe we should do a bigger operation because we can get people through it. But the underlying thing is that these are patients who predominantly have occult metastatic disease, and maybe less surgery might be better for a significant proportion of them.
Sounds like Mike needs to do the operations a bit better.
I think basically what we're debating is a local treatment for systemic disease, which is what it's about. And the reason we're debating is because we knew from times past that the local control wasn't the issue, because we all failed outside the chest, so therefore there was better filtration of radiation, was less of an impact on that background to it. And the two changes are that we now have at least chemotherapy that's marginally effective in patients who treat complete cycles and are able to tolerate it. And also with improved staging, we're a little bit more confident that there's lower bulk of disease, if you want to think of it that way, outside the chest. But the old surgical thoughts of a cancer progressing to node 1 to node 2 to liver is flawed. It's a biological progression about tricks the cells learn. And once it's learned that it can migrate to N2 in one station, it can go anywhere. So this concept of a single station N2 is just a surgical way of saying that I can get it out. That's why I think the idea of neoadjuvant therapy is really the way to go, and certainly the experience that I was brought up with, which is it gives you an individualized patient experience in the sense that you give the patient their chemotherapy, and if radiologically they respond or nothing appears somewhere else, but then you can consider that going ahead and doing your local resection with the best management you think available to the patient, which is surgery. I still think that surgery is a better local control treatment than radiation. But the key thing is how they respond outside the chest. And that's where neoadjuvant is useful, because it gives you that bit of time to see if anything else pops up elsewhere. And looking at the primary, they want to shrink to give you confidence that they're going to do well over their surgery.
So you're pre-selecting the patients whose systemic disease might have been adequately treated by chemotherapy.
But that's exactly, that is an effective philosophy for this. And at the end of the day, radiation versus surgery in the chest, surgery is a better local control. I don't think there's a huge amount of debate about that. But the reason they fail is not failure in the chest, it's failure outside the chest. So it's the treatment outside the chest or outside your surgical area that's the key thing. So this is the first sort of 5 to 10 years with some element of non-small cell lung cancer chemotherapy that's marginally effective. And hopefully in due course there'll be new agents, and I think people need to understand the philosophy behind combined therapies and what people are calling N2 disease or metastatic, potentially surgical disease, because it's about the failure outside the chest is why the patients fail. So it's therapies that focus on that or allow you to then do surgery in the chest.
So developing your own way of thinking, it probably provides a strong argument for giving concurrent chemoradiation as a first-line treatment, because then patients are getting full systemic doses of chemotherapy straight from the start, and they're also getting what's a highly effective treatment for the primary tumour and mediastinal disease, which, again, in our hands in Liverpool, our local recurrence rate, even for quite bulky T4 tumours, is less than 10%. If your centre isn't doing this, then please send your oncologist up to spend some time with us, and we'll kind of mark their cards for them.
The only problem with that approach is that then you don't know whether the primary disease, mediastinal disease, has responded to the chemotherapy or the radiotherapy, so you don't know whether the chemotherapy might have worked.
That, to me, that doesn't matter hugely. What matters is what proportion are alive at 2 years and at 5 years.
We've got time for one more question. At the back, Julia.
Just to say, obviously there's a big difference between patients who have N2 disease following surgery. It sounds like both you and Simon are indicating that's a better patient with N2 disease. Perhaps not an ideal way to go, and against teaching both the trainees in the room. Certainly, I'm not sure whether there's such good evidence.
No, I think you're right. I think if there's, I'm sure that I know by section, we're all very keen on local
dissection, I'm sure that it's not as good with that. I think there's no reason technically why you can't do as radical resection thoracoscopically. A lot of people have demonstrated, but I think it's usually then at the end of the operation, beginning with surgeons tired, cases dragging on, being asked to hurry up. There are a lot of reasons why it's not as good. It could be just about as good, but I think in practice, in reality, the limb dissection is probably not as good, not as radical with the thoracoscopic approach as it is with the thoracostomy. I mean, maybe it will be in time as people's experience increases and people's utilisation of advanced techniques improves.
Okay, thank you very much, Joe.